to multiple ASDs has been minuscule over these years. And I thought that I must touch upon this topic and also tell you how we have ourselves evolved strategies for approaching multiple ASDs. And that is the purpose of this talk, trying to share with you our experience and our philosophy. By definition, when any patient has more than one defect in the interatrial septum, we say that this patient has multiple ASDs. But it is not that simple because of a very wide morphological spectrum. And I'll just show you how wide the spectrum is, and you will have an idea as to, given the width of the spectrum, one single approach will not work in all patients. And that is why the strategy has to be tailor-made. Now, as far as the morphological spectrum is concerned, you can have a single large defect with a small strand of tissue passing through the defect, dividing it into. Sometimes you may have two separate defects which are separated by a big chunk of tissue. You may have a fossa ovalis defect. Along with that, you may have one or two tiny fenestrations in the septum primum. Or you may have a fossa ovalis defect with multiple fenestrations in septum primum. The entire septum may be multifenestrated and aneurysmal. And you can have multiple single or multifenestrated defects distributed all over the interatrial septum. And I'm now going to show you examples of each one of these morphological variations. Now, this is a classical example of a defect where there is a small strand of tissue which is separating a large defect into two small to moderate sized defects. As against this, if you look at this particular patient, you will find that there are two separate defects which are separated by a reasonably large chunk of tissue. This is an example of a fossa ovalis defect which is located more anteriorly and superiorly. And as you take your TEE further down, you will see that there are multiple fenestrations in the septum primum, very evident on color flow mapping. This is an example where you have a septum primum which is aneurysmal and there are multiple fenestrations, but septum primum forms maybe 50% or less than 50% of the entire interatrial septum, with septum secundum occupying quite a bit of the space. As against this, septum primum in this patient forms nearly 90% of the interatrial septum, with just a tiny little septum secundum here. And you can see that there are multiple fenestrations all over the aneurysmal septum primum. This is an example of the last type where you have multiple fenestrations or multiple defects. So this is a huge septum primum. There is a small septum secundum, but you can see that there is a defect here at the posterior aspect of the septum primum. Then you have something in the center of the septum primum. Then you have a large patent foramen which is separating the septum primum from the septum secundum. And this is an unusual variation where you have multiple fenestrations in the superior aspect of septum primum. I think I have very rarely seen this variation. Most of the times, the multifenestrated part of septum primum is located posteriorly and inferiorly. Now, these are the frequently asked questions. Is there a need to close all the defects in a patient with multiple ASDs? Can you close multiple defects in children? Is three-dimensional TE mandatory in dealing with multiple ASDs? And do you balloon interrogate all the patients? Or is there a role for balloon sizing? And I'm going to spend some time differentiating balloon interrogation from balloon sizing. The first question, need to close all the defects? Of course, the answer is no. If the residual ASD is hemodynamically insignificant, and this is not uncommonly seen when you have a large fossa ovalis defect with a tiny fenestration in septum primum, I think there is no reason to go after these small fenestrations unless there is a history of paradoxical embolism. But if there is no history and if the residual ASD is hemodynamically insignificant, you can just close the large fossa ovalis defect. As a matter of fact, trying to close these small defects can be counterproductive because of fear of embolization, problems of erosion, apart from the fact that it will cost you more, both in terms of money and time. The second question, can you close multifenestrated defects in children or multiple defects in children? Answer is of course yes. But our preferred strategy is to use a single ASO or single Cribriform device and avoid multiple devices in small hearts. Although there is no data to support this, I think the logic suggests that if you use multiple devices in children who have smaller hearts, there is a higher potential for complications in terms of erosion as well as in terms of compression of the surrounding structures like the AV node, the AV valves, the pulmonary veins, and what have you. Is three-dimensional TE mandatory? It is certainly preferable because it gives you a better idea about the anatomy of the defect, but not mandatory. We have been able to take care of multiple ASDs without using 3D quite safely and effectively. And in small children, many times three-dimensional TE is not possible because of technical considerations. So this is an example of really a complex ASD, as you can see here. And it's very difficult to imagine how this defect actually looks like till such time you see this defect on 3D transesophageal, where you are able to see the defects far more clearly, and you will be able to then devise a strategy, as was done in this case, by choosing two separate devices to close these multiple defects in the interatrial septum. Now let me talk about balloon interrogation and balloon sizing. Balloon interrogation we do in majority of the cases, but not in all cases. If we have decided, just looking at the anatomy, that we are going to use a Cribriform septal occluder, there is no need to balloon interrogate. However, in all other cases, we try to balloon interrogate to understand the redundancy of the tissue separating the two or the multiple defects. Now, when you do balloon sizing, you just do a stop flow technique. But when you do balloon interrogation, you are wanting to study the redundancy of the tissue. So you have to keep inflating the balloon far beyond stop flow, just to know how well the tissue separating the defects is mobile in one direction or the other. And I will show you some of the examples of this. And based on the morphology and based on the information that we have got after balloon interrogation, we decide whether we are going to use a single septal occluder, whether we are going to use two or more septal occluders, whether we are going to use one septal occluder and one Cribriform device, whether a single Cribriform device, or whether we are going to use multiple Cribriform devices. And I'm going to give you examples based on the observations that we have made. Now, this is the case that you saw, where there was a large defect and a small strand of tissue crossing over. And this can be seen even in short axis. However, these two defects were not so well seen in bicaval. Now in this, what we did. So we started first with balloon occlusion just by stop flow. And you can see that there is a definite shunt which is seen through the second orifice, which was on the anterior and superior aspect of the main defect. Now, this is what I mean by balloon interrogation. You can see that the balloon is inflated further to push the intervening tissue on one side, and we were able to push it quite effectively on one side towards the aorta. So we know that probably by using one single device, we will be able to close these two defects. And that is what we did exactly. We used one single septal occluder, and we were able to close both the defects quite effectively and safely. So this is an advantage of balloon interrogation, which helps you in deciding what kind of strategy you are going to use. Another case, here again, you have two defects. One is close to the AV valve and other is located little posteriorly. Now see what happens on balloon interrogation. So we started with the balloon interrogation of the defect which was close to the AV valve. So initially we just inflated the balloon to stop the flow. And then, as you can see here, we interrogated. Now what happens? Despite balloon interrogation, you will see that there is still a residual flow through the posterior defect. So what we did here is that we removed the balloon from this particular hole and we went in the posterior part of the defect. And with that strategy, we were able to push the tissue separating the two holes more anteriorly. So what does this tell you? Is that this tells you that the redundancy of the tissue or mobility of the tissue is not equal in all directions. This tissue was not mobile posteriorly, but when we tried to displace it from posterior towards anterior, we were able to mobilize this tissue anteriorly. Here again, if we would have gone only by the first strategy, we would have thought that we will need two devices. But because we did the redundancy test from both sides, we were able to close this defect using a single device, using a balloon assisted technique. And you can see that LA disc followed by waist, followed by RA disc, and then we deflated the balloon. And once the device was in place, we were able to release. So you can see that with a single device, we were able to close both the defects, despite the fact that balloon interrogation of the anterior hole did not allow us to push the intervening tissue posteriorly. So that is the importance of trying to interrogate from both the holes. Now this is a case where you have two devices and we start with interrogation of the inferior defect, but you can see that despite interrogation, you can see that there is a huge residual shunt. We interrogated by inflating the balloon in the superior defect. You can see that we have interrogated by a balloon which is kept here, but there is a huge inferior residual shunt. And both the shunts can be closed only by using two separate balloons. So the strategy becomes simple, that we have no choice but to use two separate devices, as was done in this particular case. And we have used one smaller device and one larger device because we were not able to displace the intervening tissue either superiorly or inferiorly. Only then you have to use two separate devices. Now this is the next case where you have a large fossa ovalis defect here. And as I showed you, you have multiple fenestrated defects in the septum primum. So how did we start? We started by interrogating the superior defect or anterior defect, which was the fossa ovalis defect. And you can see here that there are multiple fenestrations in the septum primum. So we said that we will use a fossa ovalis, we will use a septal occluder to close the fossa ovalis defect, as was done here. And you can see that the inferior multiple fenestrations were closed using a fenestrated device. So you have a fossa ovalis to close the larger defect. You have the septal occluder to close the larger defect, and you have a Cribriform device to close multiple defects in septum primum. Now, this is what happens many times when you close the larger defect with a septal occluder and you want to get back the fenestrated device, it may be difficult. So you need to recapture this, get the fenestrated device in its position and deliver the fenestrated device, and then go ahead and get the septal occluder on top of the fenestrated device and close the defect, the fossa ovalis defect, as is seen here. So we have closed, is the same patient. We have closed the fossa ovalis defect with a septal occluder and multiple fenestrations in septum primum by using a fenestrated device. Now, this is an example of an aneurysm. Now, you watch this aneurysm very carefully. If you look at this aneurysm, the major defect in the aneurysm is seen inferiorly, you can see here, and is seen posteriorly, as you can see here. Now, what happens is when you try to cross these defects, the chances of you going through the posterior and inferior defect is high. Now, in such cases, if you were to use a Cribriform device, I have a little bit of concern about the stability of the device. I like to pass a Cribriform device through a smaller orifice so that it is stable, and then it can squeeze the aneurysm and take care of the multiple fenestration. So what we did, we decided that we will try and interrogate this particular defect through the larger hole, which is located inferiorly and posteriorly, and probably is the defect through which we will enter the atrial septal defect. So then we have used this balloon, and you can see how well we are able to squeeze this aneurysm. And now we have squeezed the aneurysm completely, and we have been able to close all the defects. So this is how the balloon interrogation looks when we are trying to do this. So what is the conclusion from this balloon interrogation? That I should be able to close all these defects using a simple septal occluder and not take a chance of using Cribriform and wonder whether my Cribriform device will be stable or not. And this is what we did. We have used a routine septal occluder, and you can see that every defect is closed because the entire aneurysm is squeezed. Now we come to a similar case, but little different. This is a huge aneurysm. You see 90% of the septum is formed by septum primum. And there is a very tiny septum secundum right at the top here. Now in this case, if you see, as against the last case, the major defect is located anteriorly and is located superiorly. You can see here. Now in this case, even if you want to enter through the major defect, it will be almost impossible given the size of the aneurysm, believe me. Most of the times, you will enter through one of these smaller defects which are located more inferiorly and posteriorly. In this case, we did not interrogate this septum at all because we had made up our mind that we are going to go ahead with a Cribriform device. The total septal length, I'm not a great believer of that, but when I use Cribriform device, that is the only way you can decide what size device you are going to use, was around 32 millimeters. So we used a 30 millimeters Cribriform device. And you can see how beautifully we have been able to squeeze the aneurysm and close all the defects and look at the stability of the device. It is perfectly stable. So I'm not at all worried about the stability of the device because I have gone through a smaller fenestration in the posterior and inferior part of the septum. And lastly, this case where there are defects everywhere. There is a posterior defect here, then there is a central defect in the septum primum here. Then you can see that there is a defect between the septum primum and septum secundum. And as I said, very rare variation where you have multiple fenestrations in the superior portion of the septum primum. I have rarely seen this kind of variation. So we decided that we are going to use two separate devices, both being Cribriform, one to close the posterior defect and the other one to close the central and the anterior, central and the superior defects. And this is what we did. A smaller one, I think a 20 millimeter, a 25 millimeter to close the smaller one, and then a 35 millimeters to close the central and the superior one. And you can see that these two devices have beautifully interleaved, closing almost all the defects in the interatrial septum. So ladies and gentlemen, in conclusions, multiple ASDs is an anatomical spectrum with various morphologies, as a result of which no single strategy will fit all the patients. And that is why the approach needs to be tailor-made. We believe that balloon interrogation is extremely helpful, although not mandatory, in deciding the kind of strategy that you are going to use. It is important that you have different types and different sizes of devices because they will need to be used in various permutations and combinations to close practically all the defects. And with our experience, we can say that transcatheter strategy is a safe and effective way of taking care of multiple ASDs. Thanks for your patient hearing, ladies and gentlemen.
Thank you, Dr. Bharat. I think it was a masterly talk. Many people who are hearing Dr. Bharat should recognize that it's only after the initial 100 or so you should try to even think about closing a multiple ASD because of the extreme degrees of complexity. So of assessing an atrial septal defect, number one by echocardiography and number two by the balloon interrogation. There are a few questions that came up and I am just reading them out. One of the question was, while we are advocating a balloon interrogation, which means you are stretching the balloon a little bit beyond what is the stop flow, do we have the fear of tearing the interatrial septum? Dr. Srinivas is asking.
I think the chances of you tearing the interatrial septum with a sizing balloon, I think is minuscule. We have really never seen a tear in the interatrial septum only because of the use of the sizing balloon. Unless you really put the device and multiple times you have to recapture the device, redeploy the device, that is the only time I have seen the intervening tissue getting torn. But only sizing of the balloon just by increasing the pressure a little bit, and that would be in a sizing balloon, the maximum pressure you can generate with the help of a 20 milliliter syringe is not more than 2 atmospheres. So I don't think that is really a practical fear. I don't think you should worry about it.
Shiva, before you take questions, just a small request. Can you please make it as an interactive forum and call some of the seniors or international faculty who are all watching the program or logging in? You can ask Radha sir or KK. That is up to you, but I am just suggesting so that the program can be made very lively.
It's perfectly fine. Actually, you are also completely audible. Please take over. Just like
you being a moderator, I request you to do that.
Dr. KK, your thoughts on multiple ASDs?
Dr. Bharat has covered everything, I think, adequately.
Are there any additional points that you want to? I'm just reading out the questions that came up on the chat box. Rather than Sushil, your additional points that you would like to stress on about multiple ASDs or even about the previous two speakers.
I'm sorry, I didn't get it.
Like your thoughts, inputs on all the like how to approach a multiple ASD more than what Dr. Bharat had specified, or some places where you have better techniques of assessing multiple ASDs.
Use the same approach what Bharat has been talking, except that, you know, in the presence of one large ASD and another very tiny ASD, we would tend to ignore those tiny ASDs. And I personally feel that it doesn't affect the natural history of the disease, especially in very small atrial septal defect. Our main aim is to close the larger defect, and even if there is a tiny little flow, then I would tend to ignore it, especially if it is very small. Otherwise, the approach is more or less the same as Bharat has described, and I think that's what we also do.
Thanks a lot. Dr. Jairanganath, your views on both your predecessor's talk and your like Dr. Bharat's talk. Satya, can you unmute Dr. Jairanganath also?
I think he is not there, Shiva. You can go ahead with your discussion.
I don't have any questions. I'm just going to read out all the chat box questions only. If it is okay, then the next question is, how do you size a Cribriform device? It is available in different sizes. So how do you choose a Cribriform device size?
If Cribriform device is the only device I'm going to use, then I go by the atrial septal length. And usually we use the size which is just less than the total interatrial septal length. So suppose if your septal length comes to around 34 millimeters, then you could mostly use a 30 millimeters, unless 30 millimeters is either not very stable or leaves behind a lot of residual shunt. Then you could take that liberty of using 35. But if you have, say, a septal length of 28, then our first choice will be a 25 millimeter. And only if we have issues, then we may go up to 30 millimeters, but usually by interatrial septal length. However, if I'm using a Cribriform device along with a septal occluder. And in most of the cases where we have used, the fenestrated part of the septum was hemodynamically significant. Otherwise, we have not put those devices more often than not. So what we do is that we find the length of the cribriform portion, and usually we use a size which is one size more than the size of the cribriform part of the septum. Try and go through the center of the cribriform portion, but every time it may not be possible. And in that case, you have to go by trial and error. But we would first try and use a smaller device. Only if it doesn't work, that we would upsize the device.
Exactly. One of the
Dr. Muthu,
Dr. Bharat,
Muthu, I've unmuted you.
Suppose there are multiple defects, and you are.
I can't hear you.
Sorry.
Shiva,
Am I audible now?
can you hear me, Bharat? Muthu here.
Bol Muthu.
Very nice talk, Bharat. You frequently have the difficulties when you have multiple ASDs and you want to close the largest ASD. The wire automatically goes to the smallest hole possible. And do you have any strategies of crossing the large hole? I know you can do the balloon and do it, but I'm just saying any strategies crossing the large hole?
Yeah, see, if I have to cross the larger hole, I usually look at the anatomy of the holes. If you have a large aneurysm and if the hole is located superiorly and anteriorly, believe me, no matter how much you try, getting through that hole is really extremely difficult. Unless you are going to use a bilateral femoral access, try to push the aneurysm on one side with a catheter and then try and go anteriorly and superiorly. Otherwise, it's difficult. If there are multiple holes and I'm planning to go through a major hole for whatever reasons, then what I would do is come into the RA and try and make a small bud out of the left atrial disc and try and cross it. Or you can use a pigtail catheter to begin with and try and cross the hole, and you will be most often going through a larger fenestration than a smaller fenestration. But if you have not a multi-fenestrated defect, but if you have two separate defects, then I think going through each one of the defects, interrogating each one of the defects is mandatory in deciding the strategy. Because as we showed you, the intervening tissue may be redundant only in one direction and may not be redundant in the other direction. And that helps you a great deal in deciding whether you are going to close with a single device or whether you will require two devices.
Thank you, Bharat. Thank you.
Bharat, one of the questions that has come up from 2-3 persons, after you close the larger ASD and there is an additional smaller defect that is seen at the edges, Dr. Lokesh would like to ask, if you are going by a repeat cath to assess the QP by QS, or Dr. Prabhat is asking, is there an anatomical size of the additional defect that you would say is significant and then you will go in?
I don't think that I would only go by numbers. I think we have, all of us know that this is a fenestration which is not hemodynamically significant, unlikely to cause problems. Only if there are borderline cases where the fenestration is not all that small, I think those are very rare. Most of the times, looking at the morphology, you are able to make out whether you are going to close the defects or whether you are going to close only one of them. But if it is truly borderline, then probably closing one and then running another oximetry may be a good policy to decide whether you are wanting.
Yeah, just please log in if you are free now.
The next question, Dr. Bharat, what is the additional antiplatelet strategy on these patients who are getting multiple devices? A. Number two, many of these patients may be adults, and if they happen to be in atrial fibrillation, your anticoagulation strategy.
I think that whether it is one devices or two devices, our anticoagulation strategy has been a little different if they are in normal sinus rhythm. For a single device, even if it is a large device, and even if we are doing it in adults, we have been using 150 milligram of aspirin for 6 months. Sometimes we stretch it to a year for maybe 30 at 40 millimeters. But even in multiple devices, we have so far stuck to using only 150 milligrams of aspirin. The only time when we have used dual antiplatelet therapy is when we have thought that we are using two large devices in the same patient, septal occluders, where we think that because of some amount of superimposition of the device, the amount of endothelialization may not be adequate. We have gone, really, we have played it by the ear. We don't have policy well defined, but most of the cases, it has been a single antiplatelet.
Okay.
As regards atrial fibrillation, our policy has been to use both, use anticoagulants as well as antiplatelet. Antiplatelet, we have used 150 milligram of aspirin, and anticoagulation, we have usually maintained INR between 2 to 2.5 and never more than that. If the patient is above the age of 70, because of the concerns of bleeding, we have usually used 75 milligrams of aspirin and tried to maintain the INR to 2. I don't think that there are any studies or there is any scientific data on which this is based. I think this is empirical. Only thing I can say that it has most of the times worked for us. I have not seen many cases where patients have bled, and I have not seen cases where we have continued with this anticoagulation and antiplatelet protocol and patients have embolized. I have had a couple of patients who have had embolism post-procedure, but they did not have atrial fibrillation de novo. They developed atrial fibrillation sometimes after the procedure, which went unnoticed, and their presentation was with an embolism. So I can't say that our strategy failed. I think it was because of the additional complication of atrial fibrillation that patients went into this complication.
Okay. One of the questions from Dr. Nilesh is that headaches are more common in patients who get larger and larger devices. So what will be the frequency of headaches in patients who are getting multiple devices which expose large?
Fortunately for us, I have done now nearly 40 to 45 patients with multiple ASDs, not all of them with multiple devices. But I don't remember any patient in this cohort has come with a headache. But
in general, the approach for a headache after an ASD device closure, how do you approach that?
In our experience, the incidence is around 5 to 7%. And our policy has been to convert these patients from single antiplatelet to a dual antiplatelet. Most of them will respond within 6 weeks. I have rarely seen a patient who has gone beyond 6 weeks, in which case I have continued dual antiplatelet for 6 months. I have had no patient who has gone beyond 6 months in my cohort, although I have seen one patient done outside who has come to me after 3 years with a headache which is so severe that that patient underwent surgery after 3 years for removal of the device and closure of the defect.
Just one more question that also has been asked. Sudeep is asking, when there are multiple orifices and you are choosing to use a Cribriform device, how do you select the central orifice?
It is not always possible to select the central orifice. You can try and see on your transesophageal, but you know how tricky it is unless you have a 3D transesophageal, which many times in children is not possible. So our policy is try and see if we can go through one of the smaller holes, if it is possible. And that is possible when the major defect is located superiorly and anteriorly. And then go ahead and deploy the device and see how well it lies and how stable it is and how many defects it is able to close. If you find any instability or if you find significant residue on either side, probably you can upsize the device. And that is the way to go. I don't think that I have a trick to tell you as to how I will enter through the central hole. You try and interrogate the septum and go centrally, but it may not be always so simple as it appears to be theoretically.
Can I make a point, sir? Srinivas here.
Yes, please.
Sir. So regarding entering this different defects where there are multiple holes, a couple of things what we try. It works sometimes, it doesn't work sometimes. For example, if I have to enter a superior and anterior defect, I usually drop down from the superior vena cava. Whereas if, as in shown your slides, if the defect is directly anterior or directly facing the IVC, then it most likely goes through the IVC. So that is one strategy. So sometimes what we have done is we have closed one of the holes if with a balloon, if it is not desirable hole that we need to enter, then try to enter the additional hole with a additional access from the left femoral vein. Otherwise, alternatively, as you suggested, we can always close that and see where the defect is located, and we can cross that. How it helps closing the one hole and entering the additional hole is that you now have a planar 360 degrees structure occluding one of the hole. And when you interrogate the patient again after the hole is closed with either TE or transthoracic echo,